everyone, and thank you so much for joining us tonight for the webinar Aging, Sex Differences in Bladder Cancer. I'm Teresa Blondin, the Director of Volunteers and Programs at Bladder Cancer Canada, and I'm so honored to be facilitating this session. At Bladder Cancer Canada, we believe that education empowers patients and enhances quality of life. Tonight's session explores how biological sex differences and aging together impact bladder cancer, shaping risk, diagnosis, treatment, and outcomes. We'll also discuss how understanding these factors can improve bladder cancer care. Now I'm honored to introduce our presenter for the evening. Dr. Madhuri Koti is a veterinarian with a PhD in molecular immunology. She completed her postdoctoral training at Queen's University, focusing on molecular immunological biomarkers of treatment response in cancer. Now based at Queen's Cancer Research Institute, her research investigates how age and sex influence the bladder tumor immune microenvironment and responses to treatments like BCG. Using patient-derived samples and mouse models, her lab aims to develop non-invasive immune monitoring tools and improve personalized treatment strategies. Dr. Koti, we're thrilled to have you here with us today. You've been such a great supporter of Bladder Cancer Canada. We're so grateful for your ongoing support, and I will pass the floor to you.
Hello, everyone. My name is Madhuri Koti, and I'm an associate professor at the Sinclair Cancer Research Institute, Queen's University. Research in my lab is focused on gaining a better understanding of the crosstalks between cancer and the immune system, specifically how older age of the patient and their sex may contribute to bladder cancer progression and response to treatment. In this talk, I will present some concepts about these two major non-modifiable risk factors, that is, older age and biological sex, that are known to associate with bladder cancer progression and variable outcomes following treatment. As many of you are aware, smoking remains the major risk factor in bladder cancer. Other known risk factors include environmental or occupational factors, chronic inflammation, age, and biological sex. In this webinar, we will focus on the biological age and sex-associated variabilities in incidence and outcomes of bladder cancer. Older age is one of the biggest known risk factors for development of cancer. Before we talk about the variety of reasons how aging increases the chances of getting cancer, specifically when we look through the immune system lens, I wanted to draw your attention to this data from the Global Cancer Observatory, an interactive web-based platform that houses global cancer statistics with a goal of informing cancer control and research. As you can see, with the estimated rise in the number of older individuals, cancer incidence is also expected to rise significantly over the next 2 decades. Bladder cancer is known to disproportionately affect older adults, with 80% of diagnosis occurring in older individuals aged 65 years and older. This graph, again using data from the Global Cancer Observatory, shows the estimated rates of bladder cancer incidence across the world. As highlighted in the red box here on the right, very clearly, similar to the estimated rise in the incidence of other cancers, the incidence of bladder cancer is also expected to significantly increase in the next 25 years, although these are only predictions based on historical evidence and estimates. Very briefly about the stages of bladder cancer. Almost 75% of patients with bladder cancer present with early stage or non-muscle invasive bladder cancer, and approximately 25% present with the more advanced muscle invasive type of bladder cancer. The difference between these two lies in the depth of tumor infiltration into the bladder wall for further classification as non-muscle invasive or muscle invasive type of bladder cancer. For further details into the pathology of bladder cancer, there is another webinar by BCC that was held last year, I guess. So you could refer to that webinar to understand more about the disease. In the case of non-muscle invasive bladder cancer, following risk stratification as per the American Urological Association risk stratification criteria, patients at a higher risk of recurrence or progression are treated using repeated intravesical Bacillus calmette-guerin immunotherapy. Several patients do benefit from this immune stimulatory treatment approach that was first actually developed in Canada and has been adopted globally. But many patients do not achieve the desired benefits and experience cancer recurrence or progression following treatment with BCG. For those who do not respond to BCG, several newer promising treatments are in advanced stages, as shown here on the right. They are in advanced stages of clinical trials, or some of them are even approved. Overall, non-muscle invasive bladder cancer is quite management intensive, and some of these treatments are quite expensive too. For muscle invasive bladder cancer, however, there are several treatment options such as chemotherapy, cystectomy, radiation, antibody drug conjugates, and immune checkpoint inhibitor therapy. This guideline publication by the Canadian Neurological Association is a great resource to understand the treatment options for muscle invasive bladder cancer. So the median age of diagnosis for bladder cancer is 73 years. Elderly patients generally present with a more invasive disease and usually at higher risk of complications, are at a higher risk of complications following treatment. The graph on the left, based on recent statistics from the United States, shows bladder cancer incidence by age group. And as you can see, majority of patients are within the age groups of 65 and above. The graph on the right shows findings from a study on Canadian population. Here, researchers studied the features of the tumors that can allow urologists to better predict the disease journey. In this study conducted on 3,324 patients from Ontario, 51% patients presented with a high grade of non-muscle invasive bladder cancer, which when accompanied with other features such as multifocal carcinoma in situ, did not respond well to treatment, meaning more patients in this group progressed to advanced disease. The median age of patients in this study was 71 years. So these are just recent statistics which have not changed much over the last several decades. Another important fact that I would like to mention, although not a focus of this webinar, is the chronic comorbid conditions that often accompany bladder cancer diagnosis. These comorbid conditions in older patients are indeed reflections of age-related reduced physiological reserves in multiple organs. Quite obviously, having these make the patients more vulnerable to unfavorable outcomes. Not to mention that many patients do not have access to information and support for managing all these, including treatment-associated logistical needs. Now that I have introduced the first non-modifiable risk factor, let's get introduced to another important risk factor for bladder cancer, that is patient biological sex. Before going into the details, let's just go over the definitions. An individual's sex refers to a biological variable defined by characteristics encoded in their DNA, such as reproductive organs and other physiological and functional characteristics. It's important to remember that it's the patient's sex that has been quite widely studied, and in this talk, we will be mainly focusing on sex-related features. And for simplicity, I will be referring to people born with two X chromosomes as females, and those who have one X and a Y chromosome as males. Gender refers to social, cultural, and psychological traits linked to human males and females through social context. Differences in cancer incidence in females and males is quite well known. As you will notice here in this figure, based on incidence in the UK population, some cancer types occur more frequently in males compared to females. Bladder cancer is among the top three, where you see a higher than threefold difference between males and females. This pattern is quite similar to that observed in other countries across the world. The high incidence of bladder cancer in males compared to females is due to a combination of differences. Higher probability of carcinogen exposures in males occurs via occupational exposures to chemicals such as aluminum, rubber, paints, and firefighting. Other influences, such as those from hormones, are explained to some extent in females, but not quite well studied in males. Genetic studies have also shown that there are factors embedded in the X and Y chromosomes that influence susceptibility and progression of bladder cancer. A well-studied genetic basis of higher frequency of bladder cancer in males is the loss of chromosome Y in aging males. With aging, many males lose their Y chromosome in some cells of their body. This can occur in any cell type of the body, including cancer cells and cells in the blood, such as immune cells. A study published in 2023 demonstrated that cancer cells with a loss of Y chromosome behaved more aggressive than those with intact Y chromosome. This study also showed that immune cells within the tumors, which also often have a loss of Y chromosome in older males, also exhibit an impaired behavior, meaning they do not function as per their expected roles. The newer immunotherapy that allows immune system to partially recover from their exhausted behavior was in fact more effective in the scenarios with loss of Y chromosome. For sure, it cannot be generalized, as there are several other reasons for why some treatments will work and some will not. However, this study significantly improved our understanding of some aspects of the genetic basis of sex differences in bladder cancer. Similar studies have shown that there are certain genes on the X chromosome that play protective functions, and loss of those may be one of the reasons why the cancer is different in females and males. Sociodemographic factors also contribute to sex differences in bladder cancer. This particular study was conducted to investigate such needs in patients less than and more than 65 years. What this study found was that patients younger than 65 years of age may require more psychological, patient care and support, and communication with their spouse or partner. However, in patients over 65 years of age, health system and information needs may be more critical intervention targets. In the older age group, compared to males, females had more unmet needs in healthcare system navigation domains, including health systems and information, patient care and support, and communication with clinicians. According to this study, specific barriers exist when we compare females and males, especially with regard to their interactions with clinicians. Shifting gears a little bit, it's an established fact that inflammation is a cofactor in tumor progression. Also, our immune system works differently at different sites of our body. So how does immune response to bladder tumors looks like in the actual tumor tissue? In this example of a non-muscle invasive bladder tumor microenvironment, you can see variable distribution and density of the smaller immune cells depicted with an eye, close to the tumor epithelium, which is depicted with a C symbol there. Because the journey of cancer development is so long, we also often encounter events that are reminiscent of a once active immune response. A classical feature of immune response at surfaces of our body that are exposed to the environment, either internally or externally, such as the bladder, gut, or respiratory tract, or even skin, is the accumulation of immune cells that come together to fight persistent antigenic stimulus. For example, persistent urinary tract infection, in the case of bladder, or even cancer or carcinogen exposure. Multiple studies conducted in our lab and by others demonstrated that these cells reflect an exhausted state, meaning they are not able to fight anymore. What you're seeing in these images are such snapshots that are indicative of a once active and now exhausted immune system. In non-muscle invasive bladder cancer, these are seen in some tumors from patients with an aggressive disease, those who are older and those who are more likely to experience progression following treatment with BCG. The image on the right, the colorful image on the right, shows different types of cells. When we use a technique to paint cells with different colors to understand their distribution patterns and get to their role definition. Their presence may have different meanings in the context of treatment response in non-muscle invasive bladder cancer versus muscle invasive bladder cancer, and is a very active area of investigation. In females and males, the density and distribution patterns of immune cells that you just saw within the tumors can vary due to different influences from female or male biased events that impact the immune response, as you're seeing here in the figure on the left side. Some reasons are highlighted here on the top, such as the escape from inactivation, some hormonal influences, microbiome, loss of Y, or androgens. On the right is a plot that shows how adverse events following treatment, various types of cancer treatments are more common in females compared to males, and that it applies to various types of treatment modalities, as I just mentioned. Our immune system is the most effective weapon that keeps cancer development under control. As we get older, our immune system undergoes several changes that lead to its diminished functions, which are mostly irreversible, at least in the current era. This defense system goes through three major phases in our lifetime: early maturation, fully mature, and immune senescence or decline phase, as shown in the left figure here. These phases exhibit differences in their components and functional capabilities in males and females. Several of the immune response-related genes are present on the X chromosome, of which females have a double dose, and because of which there are some differences that we see in fighting infections and vaccine response, as we recently observed, even in the case of COVID-19. Shown here on the right are some effects of aging on the female and male immune system function. Since all these cell types are important for fighting cancer, such inherent sex-associated differences may ultimately have an effect on tumor progression and response to treatment. However, men may not be very distinctly separated when we try to define them, reasons for which are several and beyond the scope of this particular webinar. In addition to what I showed in the tumors, we also conducted a study in a local cohort of 332 patients at the Kingston Health Sciences Center here in Kingston. And what we observed was that females with high-grade disease have worse progression-free survival compared to males. We were also able to validate these findings in a totally different cohort of patients from another country, meaning these findings may be generalizable. Here are some more examples of older age and immune exhaustion associated poor response to BCG treatment in some European cohorts. And findings from both these studies demonstrated that older age and immune exhaustion are independent risk factors associated with poor outcomes following treatment with BCG immunotherapy. To further understand the effect of age and sex in cancer progression, we conducted some investigations, specifically with support from funding from Bladder Cancer Canada, in healthy aging bladders from female and male mice, and found that male and female bladders exhibit several differences in their immune response components as they age. And these findings are extendable to even human scenario. When we expose these mice to a bladder-specific carcinogen, specifically older mice, what we observed was that tumor development occurred earlier in older mice compared to younger mice, indicative of age-associated immune dysfunction, along with many other differences that we observed in the tumors from female and male mice. As an example here, we tried to restrict the expansion of one of the pathogenic or exhausted cell population. And what we found was removal of these cells led to urothelial recovery and reduced progression at a higher degree in female mice compared to male mice. In the context of sex difference in response to BCG immunotherapy, there has been a variety or variability in reports. This meta-analysis-based study on the left found that in general, female patients were more likely to experience recurrence compared to males. Another recent study conducted in a cohort of 519 patients, of which 131 were female patients, shown on the right, found similar association where female patients experienced shorter recurrence-free survival compared to males. Conflicting reports in the field exist in this area and suggest that there is an urgent need for sex disaggregated analysis to really understand what underlies such differences that are observed in female and male patients. In case of muscle-invasive bladder cancer, here you can see some differences between males and females with metastatic cancer. Particularly in this study, the researchers investigated whether there are differences in where the tumor most commonly spreads in males and females. The study was conducted in a cohort of 7,040 patients with metastatic bladder cancer. There were 74% males and 25% females within the similar age group and of similar ethnicity. The rates of metastasis, as seen here, clearly show that bone represented the most common site of metastasis, followed by lung, whereas in women, lung was the most common site, followed by bone. This study also found that thoracic metastasis increased with age in both females and males. With age, metastasis to lymph node and brain decreased in both males and females. The overall message from this study was that patient age and sex should be considered while interpreting imaging results. Some more recent findings. This recent study conducted in a cohort of 542 patients with muscle-invasive bladder cancer examined sex-related differences in cancer outcome after chemoradiation. What it showed was that females experience worse cancer-specific survival upon treatment with chemotherapy and radiation from muscle-invasive bladder cancer. So in summary, while there is substantial evidence showing the critical role of patient age and sex in susceptibility and treatment outcomes of bladder cancer, future research is needed to integrate these non-modifiable yet foundational aspects of the host immune physiology and the immune microenvironment associated features into trials that mainly use immune-based treatments, as well as in biomarker discovery, so that patients can be identified quite early in their treatment journey, and overtreatment of an exhausted immune state can be prevented, and therapeutic benefits can be improved. With that, I would like to end my talk and thank Bladder Cancer Canada for this opportunity to share some information on the non-modifiable risk factors, that is patient age and sex, and some of our research in the area. And thanks to all of you for listening.
Well, thank you so much, Dr. Koti. We really appreciate you sharing some of your amazing research with us tonight. So I hope everyone enjoyed this session. We do have 2 events scheduled for the fall. You can register for these events on our website under Patients Upcoming Events, or you can scan the QR code on your screen right now. And just a reminder about Canada Walks for Bladder Cancer. On September 20th and 21st, communities across Canada come together to create community, walk, and raise funds for our mission to provide more awareness, support programs, and innovative research, like the work Dr. Koti is doing. So we hope you will join us. You can register, volunteer, or donate. It all makes a difference. Visit bccwalk.ca to learn more. And thank you again, Dr. Koti, for your ongoing support and for sharing your cutting-edge research with us tonight. And thank you, everyone who attended.